Welcome everybody to Midlife Mayhem, debunking common menopausal myths. And today I'm Rena Malik and I'm here with Dr. Sabrina Sahni, who is a board certified family medicine physician. She specializes in women's health and midlife women's care. She completed her family residency at Virginia Commonwealth University, Riverside Family Medicine program, and went on to be dual fellowship certified in specialized women's health and medical breast, both at Cleveland Clinic in Cleveland, Ohio. She now practices in Cleveland Clinic, Florida, in the Department of Family Medicine, where she focuses on primary care with a strong emphasis on women's health. Welcome.
Thank you. Thank you so much for having me. I'm looking forward to talking all things menopause today.
Awesome. So I've always assumed that menopause is, associated with hot flashes, night sweats, and it happens around 50. And it's really just like a sign that you're getting old. But what exactly is menopause and what can women expect when they start going through the change?
Sure. And that's something that I think generally a lot of women kind of feel about menopause, that it just happens in their 50s. They can get hot flashes and night sweats, and it really is like signifying the end of one's youth. But it's time to kind of change the narrative on that a little bit and kind of explain to women that this is really just maybe an end of one chapter and the beginning of something new and really potentially great. So menopause, we know, is defined as the absence of menses for 12 consecutive months. And the average age is about 51 and a half, so right as you suspected. If menopause happens between the ages of 40 to 45, that's something called early menopause, so if it happens earlier. And we do see with South Asian women in particular, the average age is about 46 to 47. So definitely a little bit earlier than the national average at 51. Both of those are really different than perimenopause, which is kind of that transition into menopause. And so for some women, you can get a lot of those symptoms like you had mentioned, like 7 to 10 years before your last menstrual period. So you can really be going through this transition for 10 years in some cases. So that's why I think it's really important we talk about it as early as possible so that women kind of know what to expect, and that sometimes those signs can be signs of early menopause.
Wow. So you can have symptoms for 10 years. That's a long time before you even go through menopause. That's really interesting. I didn't know that. Yeah. Also, you said that South Asians generally get it younger. Is there like a reason behind that? Is there a genetic predisposition or something specific?
There's actually not a lot of data as to why. We just kind of see little patterns within certain races. So we know that Black women and African American women actually tend to have worsening symptoms of hot flashes, night sweats, and a bunch of the other symptoms you get. South Asian women, for whatever reason, it just tends to happen a little bit earlier. I also tell all my patients, especially if they're South Asian, we tend to also follow a genetic pattern. So the age that our mom went into menopause will typically follow suit with that. Maybe some of the symptoms that she really experienced will probably kind of experience similar symptoms as well.
And what exactly are the symptoms of menopause?
Sure. So there are estrogen receptors all throughout the body. So just as if you were to lose your hormone from the body, there's going to be no hormone to bind to those receptors. So if you think of it from the top, there's estrogen receptors in the brain. So things like brain fog, decreased concentration. A lot of working women will come in and complaining of decreased work productivity, that they just can't perform like they used to anymore. Word finding difficulties, it affects the hair and the skin. So a lot of women will come in complaining that their skin feels more dry, or it's starting to sag, their hair is falling out potentially. Hot flashes and night sweats, like you had mentioned, probably affects about 80 to 85% of women as they kind of go through this transition. Changes in weight, so it's kind of a change in body composition. They get this central adiposity. You can get pain in your joints. So a lot of people will mistake it for arthritic pain all throughout the body, but in reality, it might just be a transition or a sign of menopause. Other things would be including urological issues or vaginal issues. So you can get things like recurrent UTIs, vaginal dryness, pain with intercourse, and things like that.
Wow, that's a lot of stuff to go through during menopause.
Yes.
So I know that a lot of people complain about hair loss, particularly in South Asian women. What is something that people can do about hair loss?
So there are a lot of things that you can do kind of lifestyle wise. So I always tell people, optimize your vitamin D levels, get a good protein in your diet, avoid over styling. So a lot of women tend to wash their hair a lot or use a lot of products, so minimizing that. Replacing estrogen during midlife can also be very helpful as well. And then oftentimes I work closely with my dermatology colleagues to kind of optimize that treatment plan as well. There are things like PRP and different things that they can do to really help.
Oh, very cool. And tell me just generally all those symptoms. I mean, there's so many symptoms that you talked about, but some of them can obviously be can really impact your quality of life. So what are the treatments that people can seek out when they're really bothered by these symptoms?
Absolutely. So there are hormonal options and non-hormonal options. So we use a lot of medications off-label for our non-hormonal options of therapy. So we use a lot of antidepressants sometimes that have been some FDA approved to help with the treatment of hot flashes. There are medications that we use for nerve pain that can be used for high blood pressure, things like that. They don't take the symptoms away 100%, but they can certainly improve your quality of life significantly. And then replacing the hormones, such as estrogen, replacing that deficiency will help significantly. Now, you don't just give estrogen to anybody that comes, it has to come from a board certified physician, and you need to really kind of weigh risks and benefits. But much like a birth control pill, most estrogen and hormone therapies will contain both estrogen and progesterone. So women that have a uterus end up getting estrogen plus progesterone to protect the uterus. Women that don't have a uterus can take estrogen independently because they don't have a uterus. Then there's also vaginal estrogens, which you can give specifically for vaginal or urinary issues, and that can be given without progesterone because there's very minimal systemic absorption. So there's different hormone regimens, there's different routes of administration, there's pills and patches, like I mentioned, the vaginal creams as well. So it really is supposed to be very individualized.
And what are some of the side effects with these hormone therapies? I know women have come to see me and said they've had breast pain, or they couldn't tolerate hormones, or they were just scared in general about taking hormones because they were worried about cancer risk or things like that.
Yeah, so the biggest risk associated with hormone therapy, or really any estrogen containing product, is the rare risk of stroke or blood clots. So that risk carries if you are taking a birth control pill. Menopausal hormone therapy is actually a fraction of the dose of what's in a birth control pill. So it's a much lower dose, but that risk is still there. There have been large studies that have showed that transdermal, so estrogen patches, actually are the safest with regards to that risk, likely because it bypasses metabolism in the liver. We tend to see that more with oral formulations than it is dose dependent. So the higher the dose, the higher the risk. People are obviously very scared about their breast cancer risk, and hormone therapy can certainly influence a person's risk for breast cancer. The clinical risk is actually very small, despite what the media kind of portrays. So I still think the best study we have that looks at hormone therapy risk and breast cancer risk is the Women's Health Initiative, and it estimates about 6 to 8 extra cases for about 1,300 women. So when you apply all of that to a general population, clinically it's actually very small, but we do need to be really cognizant of that when prescribing, and taking into consideration family history, to have a typical hyperplasias, or something that could already increase the risk.
What about these menopausal symptoms in people who are diagnosed with breast cancer? What can they do, who have a personal history of breast cancer? What can they do?
So medications that I talked about earlier, the non-hormonal options, I use often with patients who have no history of breast cancer or even going breast cancer treatment. Actually, a medication you're probably really familiar with, oxybutynin or ditropan, has been proven to be very effective in treatment of hot flashes, specifically in breast cancer patients undergoing treatment. So I tend to use that quite a bit.
Really? I had no idea that it helps with hot flashes.
Yes, it does.
So yeah, for those of you watching, oxybutynin is a medication that I often prescribe for overactive bladder symptoms. And I did not know that it also helps with hot flashes. So that's really helpful, actually.
It does.
Great. And then what about, vaginal estrogen? So I talk about this a lot with my patients who come in with recurrent UTIs, and they still, even though the systemic absorption is low and it's considered very safe in, patients who've had gynecologic cancers or breast cancer, they still are weary of taking that. So what are some things that you offer if they're having, vaginal dryness, vaginal pain, and they don't want to take vaginal estrogens?
Right. So there are over-the-counter lubricants that they can use. So things for cleanse. If they have any external dryness, I always recommend things like coconut oil or Vaseline. There's something called vaginal DHEA, and DHEA is a precursor hormone to estrogen and testosterone. And it's actually been studied in breast cancer patients. So women that were actually on things like tamoxifen or anastrozole, which are common endocrine therapies used to treat breast cancer, found no systemic absorption of estrogen or testosterone. So that's really promising. For women that are really hesitant about estrogen, if I can convince them, there is a medication called Imvexxy that has only 4 micrograms, which is the lowest available dose. So sometimes they're more willing to do that and maybe spacing it out, more spread apart so that they're not getting such a high load, things like that.
Yeah, Imvexxy also comes in a suppository, like a small pill that you put intravaginally. So it's easy because you know exactly how much you're getting, whereas sometimes with the cream, you're not exactly sure, even though it comes with an applicator.
Right. And it's a lot less messy. So people tend to like it a lot better because they can just insert it and not have to worry about it.
Right, right. So why don't you tell us a little bit about some of the myths about menopause that you want to dispel and make sure people don't kind of follow this advice that they might see in popular media?
Sure. So probably the biggest myth out there is about hormone therapy in general, and it's that bioidentical hormone therapy is better than any kind of other hormone therapy. And what bioidentical hormone therapy means is really just a lay term kind of put out by the media, but essentially it's hormones that are structurally and chemically identical to what your own body would produce. So a lot of women think it's more natural, it's less of them putting medications in their body, but the reality is all of these medications and anything we take are all made in the lab and we're all taking them just the same way. So bioidentical, again, there's been no studies that show bioidentical is superior to what's called synthetic hormones, which are hormones that are maybe derived from plants, or a common one in Premarin is derived from horse urine. There's no benefit to suggest that one is superior to the other. Now, actually, a lot of data that we have that supports the use of hormone therapy has been seen with synthetics. A lot of the data on bioidenticals has actually been done in animals, so it's really hard to kind of translate that data to human subjects.
What would I see if somebody was marketing a bioidentical therapy to me? What would it be called? Because I haven't gone through menopause, so I'm not looking at those ads yet, and some of our viewers may not be close to menopause yet. So what should they be wary of when they see those advertisements or those things being offered to them?
So a lot of them are going to be labeled as like custom compounding, something that's very customly made to fit her specific needs. Estrogen pellets have become wildly popular and can actually be really harmful and raise estrogen levels significantly higher than appropriate for a postmenopausal woman. And like I had mentioned, estrogen and progesterone often have to be given together. So when you go to these custom compounding pharmacies or physicians who prescribe it, they oftentimes aren't going to give you the progesterone you need. So you need to be really careful about what you're getting and make sure you're going to somebody who's truly board certified. The North American Menopause Society is a great resource for women. You can find local providers online if you type in your zip code, and oftentimes, they require a lot of their physicians to take a certified exam to actually prescribe appropriately.
Great. And what about natural things people can do to help with menopause?
So, there's also now this whole large kind of media buzz about things like CBD or essential oils, things like that. And really, there's no good data to suggest that any of that is effective. I think the things that women can do, regardless of their age, is, a couple of things. One is maintain a healthy body mass index, so a healthy weight, and start that early, because it's much more difficult to develop those good exercise and dietary habits when you're 50, and much easier to do it when you're 25 and kind of maintain it into midlife. It's not only going to make that transition into menopause a lot easier, but it's also going to be a risk for a lot of other chronic diseases. Limiting alcohol, so with regards to breast cancer risk, the recommendation really says less than 7 drinks per week. I tend to tell patients less than 3. To be on the safe side for that. And then if you're a smoker, to really quit smoking. That will significantly increase your risk for chronic disease, but also make your menopausal symptoms much, much worse.
What about women who go into menopause early? Should they do anything differently than the regular, person who goes into menopause at the appropriate time?
So women that go into menopause should 100% consider hormone therapy, because estrogen really does protect several parts of the body. So when you go into menopause, you're going to lose a significant amount of bone mass, about 1% to 2% within the first 5 years. So you want to protect your bones against things like osteoporosis. The relationship between estrogen and cardiovascular disease is complex, but we know for some degree, it's cardioprotective. So, it protects your heart. So if you're young and you lose hormones, you're going to want to replace it so that you prevent the risk of cardiovascular disease. Other things would be to improve your cognition, right? So maintaining a nice hormonal status for that is also really important. So again, if you go into menopause between that 40 to 45 range, or even before 40, there's a small subset of women that do go into menopause before the age of 40, and they'll definitely need to be repleted.
Great. And then how long, so people probably may ask you, how long do you need to be on hormones then? Is it for the rest of your life?
So there's really no timeline. There's no clear-cut timeline. Typically around the age of 65, if you're still on it, we'll talk about maybe titrating the dose down or transitioning you to a patch because it's safer. But ideally, if menopausal hormones are prescribed within the first 10 years of the onset of menopause and it's maintained that way, the benefits really outweigh the risks. That's different than vaginal estrogen, which can really be prescribed at any age and can be safely used, throughout the duration of a woman's life. But systemic hormones are a little bit different. Though I do have a couple 90-year-old patients that are really, really hanging on to really low doses that I haven't quite taken off yet that are doing really well. But again, all individualized, and you really need to look at their, full medical history every single year.
Great. And so what do you want people to take home from this? What's the the most important thing you want women watching here to go home and remember from this talk?
So I want women to remember that they are their own biggest health advocates. And if you feel something or you notice a change in your body, you should really speak up about it and talk to your doctor. Unfortunately, I think menopause kind of gets dismissed by a lot of primary care doctors or general practitioners. And that's not to say that they don't care. It's really a gap in knowledge amongst many physicians because we don't get the adequate training in medical school. So speak up about what you want. Know that there are things you can do regardless of what your age is. So maintaining a healthy diet, getting regular exercise, taking your vitamin D, all of those things will be so beneficial for you. And if you are looking for a menopause practitioner, use the North American Menopause Society website to find one near you.
That's awesome. And I love how you said in the beginning that it's not like the end of your life. It's actually the beginning of something great. So I love the thought of that, because I think a lot of us start feeling like we lose our femininity, we've lost our womanhood, and we're just aging. And I think it's a really nice way and thought to say, we're still beautiful inside and out, and there's ways you can help yourself if you're having symptoms. You don't need to sit at home and suffer.
Exactly. You don't need to sit at home and suffer regardless. So absolutely, I agree with that.
Great. Well, thank you so much, Sabrina. It was so nice to have you tell us all about menopause. Can you tell us where we can find you if we need you?
Sure. So I am on Instagram at SKS_MD and on Twitter at Sabrina K. Sahni. My practice is in South Florida at Cleveland Clinic. So if you want an appointment or you want to refer somebody, give our office a call.
Great. Well, thanks so much.
Thanks so much.